We had Dr. Jeff Lee today here, who's going to talk to us about colorectal cancer screening. So, Dr. Lee holds a Bachelor of Arts from the University of California, Berkeley, and also has a master's in clinical research from UCSD, where he also completed his doctorate in medicine. After med school, he did his internal medicine residency at UCSD and then came here to UCSF for his gastroenterology fellowship, which he finished in 2014. He was here at UCSF from 2014 to 2018, and then after that, has since been in Kaiser Permanente since 2018. And is still a professor here, and we all kind of see him in journal clubs occasionally here and interacting with our fellows. He also completed an MPH at the Harvard School of Public Health in 2019. He's currently a research scientist at the Kaiser Permanente. His clinical interests are in general gastroenterology, colorectal cancer prevention, and hereditary GI cancer syndromes. And his research interests include colorectal cancer prevention, gastrointestinal cancer prevention, pharmacoepidemiology, and then diagnostic testing for GI cancers. And he's co-authored, from what I saw, over 100 publications, so very, very proficient in this field. So we're lucky to have him here today to speak to us about colorectal cancer screening. So thanks for being here, Dr. Lee.
Thank you, Alejandro, for the kind introduction. It's always great to be back. I wish I could be back in person to give this talk, but it's still an honor to be able to give this talk virtually. And so this is a topic that's near and dear to my heart. It's one of the reasons I've made that transition to Kaiser to be able to help lead a lot of the research in colorectal cancer screening. And so want to be able to share some of the work that we've done, but also others have really moved this field forward. So let's get started. I actually have some questions for the fellows, but I can't see the chat box. I don't know, Priya, Shreya, if you're able to kind of read out some of the answers for me, if that's okay. I won't call on anyone. If you guys could just, answer the questions in the chat box, that'd be great. So let's get started. So here are my disclosures. Most of my research are funded by federal grants, the NCI, PCORI, along with I do have 2 industry-related grants. However, the research support that I receive from these 2 industry grants are not related to colorectal cancer screening. Another last disclosure, I am a colonoscopist, so I do love colonoscopy. And this is not a talk about which one is better in terms of screening tests. So I want to put that out there right now. So here are the learning objectives for this talk. The first is to understand, at the end of this talk, you'll be able to understand why screening is possible for colorectal cancer. In addition, you'll be able to describe when colorectal cancer screening should start and some of the controversies related to that. And lastly, you'll be able to list at least 3 guideline recommended screening tests for colorectal cancer with level 1 evidence that is based on randomized controlled trials. So here's an outline of my talk. So the first one, we're going to talk about the importance of colorectal cancer screening. Secondly, we're going to talk about when colorectal cancer screening should start. Third, we're going to talk about what tests are recommended for colorectal cancer screening and the level of evidence behind that. And lastly, we're going to talk about the future of colorectal cancer screening. So why should we care about colorectal cancer screening? So despite the large declines in colorectal cancer mortality rates since the 1980s, there's still, colorectal cancer remains a public health burden. In fact, in 2022, over 150,000 individuals were diagnosed with colorectal cancer, and over 50,000 died from colorectal cancer. And this makes colorectal cancer the second leading cause of cancer deaths here in the United States. Fortunately, screening is possible for colorectal cancer. It makes intuitive sense for many reasons. The first reason is that colorectal cancer has a high disease burden. It's associated with a high morbidity and mortality, as I mentioned earlier on the previous slides. It's the second leading cause of cancer deaths here in the United States. Screening is also possible, and it makes sense for colorectal cancer because we know that it's detectable in a preclinical phase. And what do I mean by that is that we can actually detect cancer with our existing tests before it presents with symptoms. In addition, we know that colorectal cancer arises from a polyp, from precancerous lesions, from the adenomatous polyps and the serrated polyps. And so we know the natural history of colorectal cancer, and we're able to detect the precancerous lesions along with the cancerous component of cancer at an earlier stage. And this is due to the remarkable innovations for testing, including colonoscopy. And lastly, we know that early detection improves survival. And here is the SEER registry, cancer registry data that shows that if you detect colorectal cancer at an earlier stage, that is stage 1 and 2, your 5-year survival is at least 91%. And even at later stages, the survival is quite good for stage 3 at 72%. Unfortunately, at stage 4, this 5-year survival is about 15%. And so we know that screening for colorectal cancer makes intuitive sense for all these reasons above. In addition, we also know that we have an effective screening test to prevent colorectal cancer and reduce deaths from colorectal cancer. So here's the first question for the fellows. So which of the following screening tests have been shown to be effective in reducing colorectal cancer incidence or related mortality based on randomized controlled trials? A, guaiac-based FOBT, B, the fecal immunochemical test or FIT, C, sigmoidoscopy, or D, colonoscopy. And there could be more than one right answer for this one. I'll give you guys 30 seconds to.
Jeff, do you just want them to put it in the chat?
Yeah, if they could put it in the
Okay,
chat box.
Perfect. And then Ollie's going to help you monitor the chat.
Thank you. All right. I just saw the chat box right here. That's great. Ollie, what answers do we have so far?
We have Donna said colonoscopy. Ashton also said colonoscopy. And then the fellows room saying definitely colo, but all of the above question mark. And then my saying A and C.
Yeah. All right.
I think we're getting kind of a little, definitely colonoscopy and all of the above possibly.
Okay. So actually the answer is A, C, and D. So if the only test that we don't have randomized controlled trials showing effectiveness data is actually FIT. So if you answered A, you're correct. If you answered C, you're correct. And if you answered D, you're correct. So we actually have level 1 evidence from randomized controlled trials showing that guaiac-based FOBT, sigmoidoscopy, and even recently with colonoscopy can either reduce colorectal cancer incidence or even colorectal cancer mortality. And so we actually have level 1 evidence that really emphasize that screening works for colorectal cancer. And this is why it's possible and feasible. And this is what we do for 50% of our time is actually performing colorectal cancer screening for the population. In addition to showing that colorectal cancer screening works in randomized controlled trials, we also see it demonstrated in the real world. Here's a study that we published back in 2020 where we highlighted some of our experience here at Kaiser Permanente, Northern California, where screening was implemented in early 2006. And at that time, the screening rates was about 40%, so pretty abysmal. And what we did was we rolled out a outreach approach with FIT combined with colonoscopy in reach. And what that resulted is, back in 2015, was that our screening rates reached up to 83%. And as a result, our population showed a 52% reduction in colorectal cancer-related deaths. And this just demonstrates that colorectal cancer screening is actually quite effective in the real world. So when should we start colorectal cancer screening? So since the 1990s, many guidelines, including the American Cancer Society, the U.S. Preventative Services Task Force, along with all the GI societies and the radiology societies, recommended that screening should start at age 50. And the rationale behind that was the rising incidence appeared to start right at the age of 50, along with randomized controlled trials demonstrating that fecal occult blood tests was highly effective in reducing colorectal cancer-related mortality. And so that was in the early 1990s. And this is what the guidelines recommended, starting at age 50. And the shift towards a younger age really didn't start until the early 2000s or the late 2000s. And the first guideline that actually reported that we can actually reduce the age to 45 was actually the American College of Gastroenterology. And that what they wrote in 2008 was that to consider starting earlier screening for Black Americans that were average risk and asymptomatic. And the rationale behind that recommendation, even though it was weak, even though the evidence was really weak, was that there was a growing incidence in Black Americans, and they were getting diagnosed at more advanced stages when they were in their 40s and 50s. And so that catapulted a shift towards earlier screening, particularly in Black Americans. Unfortunately, this wasn't really implemented widely here in the United States. And the reason why is that for implementation to really get embedded in clinical practice, it really has to correspond with funding. And so reimbursement didn't really, insurance companies didn't really reimburse for colorectal cancer screening at 45 for Black Americans in 2008, mainly because it wasn't endorsed by the U.S. Preventative Services Task Force, which is the main guideline that Medicare, CMS, along with all insurance companies, really use to guide reimbursement. So actually 2008 was when the colorectal cancer screening age was slightly lowered to 45 for Black Americans. Now in 2008, there was a huge shift, so a decade later, and the American Cancer Society recommended that colorectal cancer should start at 45. And this was in response to the rising incidence of colorectal cancer in young adults. However, in 2018, the US Preventive Services Task Force looked at the guidelines and looked at the data at the time and didn't feel compelled that they needed to shift the age down to 45 because there's no recent data of randomized controlled trials, nor were there additional modeling data to support that recommendation. However, in 2021, there was additional data, mainly from incidence data and mortality data, that really, kind of guided the U.S. Preventative Services Task Force to be able to lower the screening age to 45. Now, more recently, I'm sure you saw this in the recent headlines, was that the American College of Physicians actually did not recommend screening at 45. And we'll talk about some of the controversies related to this. So why the lowering of the screening age from 50, which was set back in the 1990s, all the way to 45? Why did the U.S. Preventative Services Task Force, along with all GI societies, recommend that we should start screening at 45? And what's the controversy behind this? So number one, we see growing data that there's rising incidence of colorectal cancer in young adults less than 50 years of age. And here on the graph on the left, you can see that the increasing incidence particularly starts in 1990s, and it continues to go up to this very day. And that incidence is particularly higher among those who are 45 to 49. And you can see that in the green graph, or the green graph on the figure to the left. However, that incidence rate, it's still twofold less compared to those that are 50 to 59 here on the right graph. So even though the rising incidence in young adults is going up in the 45 to 49, it's still twofold less compared to those who are 50 to 59. Another important data that really drove the guidelines to shift towards 45 was that you could see the mortality data related to colorectal cancer was also increasing in those who are 45 to 49. And this is in contrast to those 50 to 59, 60 to 69, and 70 to 79. You could see declines since 1999 in terms of mortality rates compared for colorectal cancer. But what you do notice that here in red, that the increase in mortality rates for those who are 45 to 49 is quite small. Because there hasn't been a randomized control trial showing the efficacy of colonoscopy or colon cancer screening in those that are 45 to 49 years of age, what we had to rely on, and this is what the guidelines had to utilize, were these simulation models. And these simulation models require inputs from risk factors, screening behaviors, and diffusion of new treatments. And you input these numbers into these cancer models. There's actually 3 colorectal cancer screening models in the United States. And what you get are outputs from these models. And you get outputs such as colon cancer incidence, mortality, the quality of just life years, along with costs associated with if you lowered your screening age. And this is what they did back in 2021, is that they imputed the incidence rates along with the mortality rates for those that are 45 to 49. And what they found, and they were able to, this was their outputs, was that what are the benefits and what are the harms of earlier screening? Meaning, if you lower the screening age to 45, what are you going to be able to show? And what they were able to find was that if you lowered the screening age, whether you use FIT annually or colonoscopy every 10 years, whatever the screening approach is that you're able to prevent 3 additional colorectal cancer cases per 1,000 screen if you lower the screening age to 45. In addition, you're able to prevent 1 additional death from colorectal cancer per 1,000 screen. On the flip side, what are the harms when you lower the screening age to 45? Well, if you use a colonoscopy every 10-year approach, you're going to incur about 2 additional complications. Complications such as GI, perforations or GI bleeding, or even cardiovascular complications such as MI or arrhythmia per 1,000 screen. In addition, one of the main things that the modeling can also show is that there's a high cost associated with this. But one thing that the U.S. Preventative Services Task Force doesn't account for in their recommendation is actually costs. So there's a higher cost if you lower the screening age, and the output is that the benefits is that you prevent about 3 additional colorectal cancer cases and about 1 additional, you prevent 1 additional death from colorectal cancer. So in 2021, along with the GI societies and the U.S. Preventative Services Task Force, they all recommended that screening should start at age 45, and they gave a level B evidence because we don't have randomized control trial to support that. Now, why is this important is that all insurance companies, including Medicare and CMS, they have to reimburse for earlier screening. And that's why it's widely implemented currently right now. So what are the available screening tests for colorectal cancer? And we're going to talk about all of these for the next part of our discussion. So here we have stool tests, we have endoscopic imaging tests such as colonoscopy, sigmoidoscopy. We have CT colonography, which is widely available at UCSF, but not other places. We have capsule colonography and we have some blood tests that are available for the public. So the next question to the fellows, which of the following tests is not recommended for colorectal cancer screening by the United States Preventative Services Task Force? So Ollie, if you don't mind monitoring the chat. So let's give 30 seconds for everyone to enter your answers in. Which of the following tests is not recommended for colorectal cancer screening by the U.S. Preventative Services Task Force?
Yeah, so far 4 people are saying B.
Awesome. And that's correct.
Another B. Yep.
Yep. So this is what the current guidelines recommend for colorectal cancer screening tests. There's so many guidelines that are out there for the public and for clinicians. But the main one that I rely on, that the insurance companies rely on, and what you should rely on is the U.S. Preventative Services Task Force, because you want to be able to recommend a test that's actually going to be accessible, and it's not going to incur a huge financial burden to your patients. So you want a cancer test that's actually going to get reimbursed. And so the U.S. Preventative Services Task Force recommend a FIT annually, a colonoscopy every 10 years, a sigmoidoscopy every 5 years, or a CT colonography every 5 years. And lastly, they recommended a multi-target stool DNA every 3 years. Now, in contrast, the U.S. Multi-Society Task Force, which consists of all the GI societies and the ACG, what they recommend is that they have 2 tiers. They have a preferred test, and then they have a second tier test. And their preferred tests are FIT and colonoscopy, because they felt that this balances cost, but also has the strongest evidence supporting these 2 tests. So it's either FIT annually or colonoscopy every 10 years. In addition, they also provide an option for capsule colonography. And this is another option if anyone's refusing to get a colonoscopy or a FIT. This is a potential option, is to consider a capsule. Now, keep in mind that capsule colonography is not reimbursed. And so this is one thing you want to be mindful if you have a discussion with your patients who, come to you and are hesitant about a colonoscopy and they want to talk about a capsule colonography. That is one of the main limitations about capsule, is that even though it can be very accurate and highly sensitive for detecting colon cancer, the issue is reimbursement. So let's talk about stool-based testing for colorectal cancer. There are 3 widely available stool-based tests in the market currently. And it's hard to miss commercials with Cologuard or MPET, either on Super Bowl commercials, on Saturday Night Live, or even on NPR if you're listening to NPR. So you'll hear a lot of commercials on Cologuard. Now, the other type of stool tests that have been out and widely available since the early 1990s is actually the guaiac-based fecal occult blood test, along with FIT, or fecal immunochemical test. And the difference between the guaiac-based fecal occult blood test and FIT is that FIT is way more specific for human blood. And the reason why is because its technology is that it uses an antibody specific to human hemoglobin. So there's less false positives related to FIT. Whereas guaiac-based fecal occult blood test really requires the peroxidase activity of blood, along with the oxidation of the paper itself from the hemocolt. So what's the evidence behind stool-based testing? Like I mentioned earlier, there's actually no randomized control trials for FIT or even multi-target stool DNA that have shown that those 2 particular tests can reduce colorectal cancer incidence or even colon cancer-related mortality. But what we do have is that the guaiac-based fecal blood test can reduce colorectal cancer mortality in randomized trials by up to 21% if you use it every 2 years. And if you use it annually, this is what we do here in the United States, you can reduce colorectal cancer deaths by 33% compared to no screening. And so these were the landmark trials, 4 of which were published in the early 1990s. It really catapulted and put colorectal cancer screening, in the limelight for the population. And these were studies that came out of the US along with Europe. And so this is the reason why stool-based testing has been an established modality here in the United States. And I want to just point to some of the little nuance of the data is that if you look at the trials, the participation rates for these trials were actually quite high, nearly 60 to 80%. And I want you to remember this number because we're going to talk about another trial where there's low participation. But some of the limitations of guaiac-based fecal occult blood tests, as I mentioned earlier, is that there's actually medication and dietary restrictions because these can increase your false positives for the guaiac-based FOBT. Now, more recently, there's the development of the FIT test, and you guys see that in your current clinical practice. And I want to ask you all, what is the current sensitivity of single FIT for colorectal cancer in an asymptomatic average risk population? So is it 25%? Is it 50%? Is it 79%? Or is it 89%? And this was actually a board review question. So what is the sensitivity of a one-time FIT, not a programmatic FIT, just a one-time FIT for colorectal cancer in an average risk population? And sensitivity means the ability to detect colorectal cancer in your population.
So far, we have 5 answers saying C, 1 person saying D. We got another C. Yeah, that's about it. Mostly C's.
Okay, so that's correct. It's C, 79%. So where does that data come from? So it actually comes from a meta-analysis that was published back in 2014 in the Annals of Internal Medicine. And it looked at 19 studies, and it looked at the pooled sensitivity for colorectal cancer and showed that the ability to detect cancer was about 80%. So it's going to miss 2 out of 10 cancers after a one-time application. So it's not the perfect test, but it's a pretty good test. And I'll show you how it compares to the guaiac-based FOBT. So the sensitivity for a one-time FIT is about 80%. The specificity is about 94%. And one thing that we don't know is that if you lower the cutoff of FIT to a lower cutoff, you can actually improve the sensitivity to about 90%. But in current practice right now, the cutoff is about 20 micrograms per gram of feces. So that's what it's approved by the FDA for its current use. The one huge advantage for FIT compared to the FOBT is that you don't need any dietary medication restrictions. So you don't have to worry about false positives with this. However, one of the main limitations, like I mentioned, is that it's not perfect. 2 out of 10 patients, it's going to miss 2 out of 10 cases of colorectal cancer. And so this led to the development of the multi-target stool DNA. And you'll see a lot of commercials marketing Cologuard, which is the brand for multi-target stool DNA. And it's been through multiple iterations over the past decade. And what it was designed to do was improve its ability to not only detect colorectal cancer compared to FIT, but they were able to look at markers to look at serrated lesions, because one of the main disadvantages of FIT is that it's not particularly sensitive to detect serrated lesions because they rarely bleed, right? It makes sense. The ones that bleed are cancers and adenomatous polyps, but rarely do you see serrated polyps bleed. And even when you look at serrated polyps optically, you could see that there's very little blood vessels associated with that particular lesion. But we all know that colorectal cancer can arise from the serrated pathway. So that was one of the technological advantages of the multi-target stool DNA, was that they looked at specific markers for serrated lesions. And these markers were the methylated BMP3 and the methylated NDRG4. And these are specific for serrated lesions. In addition, it looked at common molecular mutations for colorectal cancer in general and adenomas, and these are KRAS and B-actin. And one thing that you may all not know is that embedded in the Cologuard kit is actually a FIT test. So it's actually a FIT plus DNA test. And so in the landmark trial that was actually published in 2014 called the Deep Sea trial, among 10,000 average risk individuals, they compared FIT and the multi-target stool DNA among individuals that all had a colonoscopy. And so they requested that they delivered the stool, and they compared, which one's more sensitive and what's the performance characteristics between the two tests. And not surprising that the stool DNA, the Cologuard, had an improved sensitivity. Remember, it's actually a FIT test plus some DNA markers. So it's got to be better than a FIT test alone. So FIT showed a FIT sensitivity about 74% for colon cancer, and the multi-target stool DNA was about 92%. So not perfect, but still pretty good. It'll miss 1 out of 10 cancers. Now, another improvement of Cologuard compared to FIT is that it's much more sensitive for advanced adenoma, 42% versus 24%. So you can see that if this was embedded in a trial, that there is a potential that Cologuard, along with FIT, can actually prevent colorectal cancer because it can detect these advanced adenomas, but not at a high sensitivity. Now, one dramatic improvement is that Cologuard improves, has much higher sensitivity compared to FIT for advanced sessile serrated lesions. And what I mean by advanced sessile serrated lesions are those that are greater than 1 centimeter. Now, the disadvantage of Cologuard is that its specificity is about 87%, and so there's a higher false positivity rate. So one of the concerns about Cologuard is, what if the colonoscopy is negative after a positive Cologuard? What do you do in that situation? Because this particular test detects DNA in the stool, like aberrant DNA. So there must be a little bit of anxiety amongst colonoscopists when that situation arises. And it's actually quite common, that this scenario happens when you have a positive Cologuard and negative colonoscopy. So in a study that was published in 2020, Barry Berger and his colleagues looked at 1,200 individuals, and they followed them up for about 5.3 years. So that was a median follow-up time. And they looked at the situation where patients either had a negative Cologuard or a positive Cologuard, followed by a colonoscopy that was negative. Negative for cancer, negative for adenomas. And what they found was that the risk of developing an aerodigestive cancer, a cancer in the oral pharynx, a parotid cancer, salivary gland cancer, esophageal, gastric, or small intestinal, or even colorectal cancer, was incredibly rare. And the difference, the relative risk, was 0.4, and this was compared to the expected cancer rate for those particular cancers in the background based on the SEER Cancer Registry. There's actually no difference. If you could see, there's a relative risk of 0.4, actually a marked reduced risk if you had a negative colonoscopy and a negative Cologuard. But that's not the situation that we have. What we have is patients with a positive Cologuard and a negative colonoscopy. What's the risk of developing an aerodigestive disease following that? And so after 5.3 years, there's really no difference compared to the background incident rate for those particular cancers. And what they conclude from this study was that you don't need to do additional testing after a high quality colonoscopy following a negative colonoscopy. So that provides a little bit reassurance that you don't have to go through a diagnostic odyssey. You don't have to, lose sleepless nights, have sleepless nights because of this particular situation. So here's a summary of the performance characteristics for stool-based tests I just want to highlight for you all. So the sensitivity for FOBT is about 24% to 36%, depending on what type of FOBT you're using for colorectal cancer. And as I mentioned earlier, alluded earlier, that FIT is performance characteristics markedly better compared to that. It's about 79% or 74% based on the DeeP-C trial. And then the Cologuard is about 92%. So every iteration of the stool-based test has really improved the sensitivity of colorectal cancer, in addition to sensitivity for advanced adenomas. So there is a potential that FIT and Cologuard can actually help prevent colorectal cancer. In addition, these tests are actually really good at detecting colorectal cancer at a one-time, use. So let's move on to endoscopic screening tests, so sigmoidoscopy and colonoscopy. So question to the audience. So based on randomized trials, a flexible sigmoidoscopy compared to no screening can reduce colorectal cancer-related mortality by up to what percent? A, 30%, B, 40%, C, 50%, or D, 60%. So what's the data behind flexible sigmoidoscopy? And this is based on randomized controlled trials, so it's compared to no screening.
So it looks like my set A, Christina B, option B. Lakshmi B, Edgar C, Stephanie C. I'm going to say D just to put the full spectrum.
All right, thanks. So it's actually A. So the mortality reduction is actually not that high after flexible sigmoidoscopy, and that makes sense. And so if you look at the data, there's actually 4 randomized controlled trials, one from the US and the others are all from Europe. And you could see that a one-time sigmoidoscopy can decrease colorectal cancer incidence, the incidence by up to 20%, and mortality by up to 31%. So it's about 30% is what I quote to my patients. And this is just a one-time colonoscopy. And this is largely due to, you're like, well, how can you reduce colorectal cancer incidence along with mortality? And so sigmoidoscopy, as you know, is flexible endoscope that really examines the distal aspect of the colon. And so not only can it actually inspect the colon, it can actually remove polyps in the distal colon itself. And so this reduction is mainly due to reduction in distal disease or distal colorectal cancers, such as cancers in the sigmoid, descending colon, along with the rectum. So not that high of a reduction. Now, if I gave this talk about 2 years ago, and I've given this talk many, over the past decade, I would say, this is what I've been quoting for colonoscopy. Up until now, like this year, there hasn't actually been any randomized control trial supporting colonoscopy's effectiveness in reducing colorectal cancer incidence or even mortality. And so there's actually some really high quality observational studies that were published in the early 2000s and the 2020s. Even there's one from Dr. Shergill from the VA. And I think Ma Sumsuk was actually part of that study too, who helped lead that study. And what they were able to show was that compared to no screening, if you did a one-time colonoscopy, you could reduce the risk of colorectal cancer by up to 91%. So pretty impressive results. And this is based on observational studies. Now, how about colorectal cancer-related deaths? Now, what I've been quoting actually based on observational studies, is that these case control studies and cohort studies showed that you could reduce deaths related to colorectal cancer by up to 70%. So pretty marked reduction in colon cancer deaths compared to no screening. Now, the landmark study that came out this past year was the Nordic trial. And I'm sure all of you are aware of this because you had your family members, you saw it in the media, and you have patients ask you, are we supposed to doubt colonoscopy's effect? So this was a trial that was conducted among 10,000 individuals. It was a population-based study in Norway, Sweden, Poland, and the Netherlands. And this trial invited individuals in these countries. Colon cancer screening was actually not widely available, and it was not recommended at that time. And they invited individuals, 10,000 of them, to this trial, and they invited them to participate. Like, would you be willing? They send a little postcard, essentially. Would you be interested in cancer screening, particularly with a colonoscopy versus usual care? And usual care was no screening at all. And you'd be randomized to that. And so they invited individuals for a colonoscopy. And what they found was that the participation rate in the invitation arm was actually 42%. And they were hoping, and they powered their study for about a 50% participation rate. And they got something lower than that. And they published their interim study, their 10-year result this past year. And their plan is actually to have a 15-year results. And this will be published in about 5 years. But they wanted to show us the 10-year result data. And so I'd like to, cross out this effect. What we're really looking at is the effect of colonoscopy invitation, because that's what really tested. But long story short, let's talk about the data. And what this data showed was that if you invited individuals for a colonoscopy compared to usual care, you were able to reduce the incidence of colon cancer by about 20% here on the graph to the left. In addition, you're able to reduce mortality related to colorectal cancer about 10%. However, this was not statistically significant. As you can see, the relative risk, as you can see, this crosses over 1. And so this was a huge, huge important piece of data, because what we've been quoting for our patients is that we would see about a 70% reduction in death and a 90% reduction in colon cancer cases. Now, this is in stark contrast in the real world or in a randomized controlled trial. Now, what they did was they did a subgroup analysis. So what if we looked at patients that actually participated among those 42%? What did the results show? And if you looked at the per protocol analysis, which can be flawed and biased in its own nature, because you're really just looking at people that are motivated to get that, what they found was that you could reduce colorectal cancer by 30% and mortality by 50%. So that's the best case scenario if everyone participated. But of course, not everyone participated, and there's a lot of controversy behind this study. Now, what are some of the controversies and some of the limitations? And this is one thing I would like you all to really just understand why the results came out to the reason why, that these were the results. Well, number one, the participation was low. So you're not going to be able to show really good effectiveness if people don't participate. It was 42%. And this is in contrast if you saw the sigmoidoscopy trials and then the FOBT trials, where the participation rate was much higher. Even in the flexible sigmoidoscopy trials, you had participation rates in the 60s to 84% rate. So that was one of the limitations. Another bizarre finding, which I want you to highlight in the graph to the left, is that there was no evidence of stage shift. If you introduce colon cancer screening, the whole point of it is to actually have to detect early stage cancers. But what you see in the early, stage A and B, this is stage 1 and 2. These are what you see in the colonoscopy arm. There's really no difference compared to usual care. You don't see a huge shift, in terms of early stage cancers. And this makes you makes you wonder, like, who participated? Could it be that the patients that were randomized actually had symptoms, and those were the ones that actually took the offer of getting a colonoscopy, knowing that that colonoscopy was going to be reimbursed or covered by the trial? So that is one bizarre finding that we've never seen in other previous studies from FOBT or even FlexSig. So that was a really bizarre finding that may explain some of the results of this trial. We also don't know information on screening utilization in the usual care group. So I know, like I mentioned earlier, there was no outreach. It wasn't part of guidelines in Europe at that time, but colon cancer screening was widely available in the United States. And there must be individuals that must have had or considered or asked about colon cancer screening in their population. But we actually don't know how much utilization occurred in that background. And the last point I want to make is that 1/3 of the endoscopists that performed colonoscopy actually had an ADR below 25%. And that's really important because that means that the quality of the endoscopy, 1/3 of them was actually below standards. And what is ADR? Just to remind everyone, it's a proportion of, among patients that undergo a screening colonoscopy, how often are you finding an adenoma? And so it's a quality benchmark for all endoscopists that we measure each year. And it's an important quality indicator. In 2016, we have established benchmarks for colonoscopy for adenoma detection rate. And this will be highlighted in a lecture by Tanya Kaltenbach. I know she's given this in the past on how to perform a high-quality colonoscopy and what it means to perform a high-quality colonoscopy. But I want to mention to you all that there's many phases of performing a high-quality colonoscopy. You have to clean the colon, you have to reach the cecum, you have to inspect the colon really carefully, but you also have to detect adenomas. And the recommended adenoma detection rate is about 25%. And 1/3 of the individuals or the endoscopists that performed colonoscopies in that trial fell far below the recommended target rate of 25%. And why does that matter? We know from several studies from the Polish group, along with here in the United States from multiple medical centers at Kaiser, along with UT Southwestern, that we've been able to consistently show that ADR is inversely associated with post-colonoscopy colorectal cancers or interval cancers. Here in the graph on the left from the Polish group, that we see that the lower your ADR, the higher chances or the higher incidence of a post-colonoscopy colorectal cancer. And this was recently also supported by a publication out of our group, and this was published in JAMA. And you could see here in the gray curve and the navy blue curve that if you have an ADR lower than 25% or even 20%, your chances of getting a post-colonoscopy, or the patients that get their colonoscopy performed by an endoscopist with a really low ADR, their chances of getting a post-colonoscopy colorectal cancer is nearly 2-fold higher compared to those that had an ADR in their 30s or 40s. So that's why it's critically important to ensure that if you're undergoing a randomized trial, that you have participants or endoscopists that are actually performing a high-quality colonoscopy. Furthermore, we also see consistently that ADR is inversely associated with post-colonoscopy colorectal cancer death. So among physicians that have a high ADR compared to those that have a low ADR, those patients that get a colonoscopy from a high quality colonoscopist, their chance of developing or dying from colorectal cancer is dramatically reduced by 50 to 60%, especially if their colonoscopist has an ADR in the 30s or above. So as one Health Day reporter nicely summarizes in a headline news, is that the doctor who does your colonoscopy matters. And this is why a high quality colonoscopist like Dr. Turdeman has a wait list all the way until 2025 for his next colonoscopy appointment. A little tribute to Jonathan Turdeman. I actually don't know what his waiting list, but I probably can predict his next available is actually 2025. So not to belabor the point, but I want to make sure that, there's a lot of flaws in many of the colorectal cancer screening tests that I mentioned earlier, from the stool-based test, which is an imperfect test. FIT misses about 2 out of 10 cancers. Cologuard misses 1 out of 10 cancers. But we also want to be mindful that colonoscopy is not perfect. It's actually operator dependent. And this is a stark reminder from 5 different studies that shows wide variability in ADR, up to 7-fold. And so you could see, based on the number of GI doctors in their group, ranging from 10 to over 100, there's wide variability in terms of performance for ADR, nearly a 7-fold difference. So let's talk about some imaging studies that are available for colorectal cancer screening. There's 2 that are widely available. Actually, there are 2 that are recommended by our current guidelines. One by the U.S. Preventive Services Task Force, and the capsule by the GI societies. I want to remind everyone that both of these tests require a bowel preparation along with dietary restrictions. And some would argue that these, some would classify, the guidelines would classify these as non-invasive. And in fact, I would like to argue that actually, a CT colonoscopy is quite invasive. There's actually a rectal tube that gets inserted into your rectum about 10 centimeters up to 20 centimeters up. And they insufflate this with air. So it's actually quite, it's almost like a sigmoidoscopy, and it's actually quite uncomfortable. So you want to be able to educate your patients who come to you about CT colonography because, first off, President Obama had it, when he was during his presidency. And they want to ask you, is this a very good non-invasive test? You want to be able to correct them that it's actually quite invasive. So what's the performance characteristics for CT and capsule colonography? What we really know is that it's actually pretty accurate in terms of detecting colorectal cancer, pretty much over 95%. In terms of advanced adenomas, it's actually pretty accurate for 1 centimeter polyps. So I want to be very clear. We don't know what the true sensitivity for a 4 millimeter tubulovillous adenoma or a 5 millimeter, high-grade dysplasia adenoma, which is really rare. But what they've shown in their studies, in these pooled studies, that the sensitivity for a 1 centimeter polyp is about 80 to 90% for both capsule and CT colonography. One thing to note is that we really don't know its performance characteristics for serrated lesions. And obviously, you all know and have been humbled by even colonoscopy has a hard time detecting these serrated lesions because how incredibly flat and subtle these are. So the last aspect of my talk is I want to mention the future of colorectal cancer screening. So you're going to have a lot of patients that are going to ask, what's next? What's in store? So we actually already have one FDA-approved blood test, and that's called the Septin9 or the EpiProColon. This particular test, as you all know, is not recommended by the U.S. Preventative Services Task Force, even though other GI societies say it's recommended, but it's really low quality evidence behind it. Now, why does the U.S. Preventative Services Task Force not recommend it? It's mainly because of its performance characteristics. It has far inferior ability to detect colorectal cancer compared to the stool-based test. If you look at the sensitivity for Septin9, it's about 50%. So it's going to miss 5 out of 10 cancers. Now, it's also incredibly poor in detecting advanced adenomas. And so that's why it's not recommended by the U.S. Preventative Services Task Force. However, it is FDA approved. So it's available if patients want to purchase it out of pocket. Now, more recently, there's many companies, the Guardant Health and the Freenome study, that have conducted really large, pivotal trials looking at their products. And their blood tests are really unique because it's looking at circulating tumor DNA or circulating free DNA, RNA, or even proteins. And they had preliminary results have been what they've been able to show is that their sensitivity for detecting colorectal cancer is actually quite high in the 80s to 90%. And their specificity is about 90%. Unfortunately, and we'll see what Freedom study, the results come out in about a few months from now, what is its sensitivity? So right now, what we could say that these blood tests are more for detecting colorectal cancer. It's probably going to reduce colorectal cancer mortality because it'll detect it at an early stage, but it may not have preventative. It may not be able to be preventative because its ability to detect advanced adenomas are pretty poor right now. Another new technology that's emerging that was labeled as the Time Innovation of the Year for 2022 is the multi-cancer early detection test. So you'll be able to detect up to 50 cancers with a single blood draw. And this is using technology and innovation from protein biomarkers for circulating free DNA biomarkers that's shed from the tumor into the blood. And you can look for ovarian, colorectal cancer. I know we have Sun Dye over here. We could look at pancreatic cancer, lung cancer, breast cancer, all within one blood draw. Now, this is, even though it's really innovative from that perspective, there are many questions and issues that remain unanswered. And sadly, it's already FDA approved for one test by Grail. It's called the Gallery test. And it's actually available for about $1,000. So you'll have patients actually get an MCED test, a multi-cancer early detection test, and they'll come to you because it lit positive for a tissue of origin from the colon, and you'll have to act upon that with a colonoscopy. But what if it's you don't know what the tissue of origin is, and there's issues with that with these blood tests? And then what do you do if you actually perform, it says colon by origin, but there's a negative colonoscopy? Do you do further testing because you know that these are DNA markers that's being shed? So you might go through a diagnostic odyssey. The other question is, does it improve clinical outcomes? Are we identifying these at an early stage and actually improving survival? We don't know about these tests, but they're already getting rolled out in the public. And like I mentioned, it's actually out. You can order it online for about $1,000. And lastly, what's the psychological and emotional burden related to these tests? Because if you can imagine, what if the test is positive and then you do actually, go through a diagnostic odyssey, colonoscopy's negative, PET scan's negative, CT's negative, what's the emotional burden? What's the anxiety for these patients afterwards? And how do you reassure them? And so there's a trial that's going to be conducted next year. And we are actually one of 4 sites that are about to test these MCEDs in terms of feasibility. And hopefully this will lead to another pivotal trial that will look at the effectiveness of these MCEDs in reducing cancer-related mortality. So we are one of 4 sites, and I'm the lead PI for that. We will be testing 2 MCEDs compared to usual cancer screening, and excited to be able to lead that effort. But we won't have the results for that for at least 5 years from now. So this is called the Vanguard study. So stay tuned. You'll see a lot of publicity, media attention on multi-cancer detection tests. And so we will talk about the take-home points. In summary, colorectal cancer remains a public health burden. It's the second leading cause of cancer deaths in the United States. But the good news is that colon cancer screening is effective in reducing colon cancer incidence and deaths from colorectal cancer. We now have randomized controlled trials demonstrating that from FOBT, sigmoidoscopy, and now colonoscopy. We talked about when colorectal cancer screening should start at 45. And so 45 is the new 50. And lastly, the preferred screening tests based on our current recommendation, our current guidelines, is colonoscopy and FIT. And I want to thank you all for your attention and open to questions.
All right, thanks so much. I think we are right on time at 9, Dr. Lee. I see the liver seminar is already logging on here. If there's any pressing question, is it okay if people
Yeah, they could chat, they can email, I can answer their
Okay.
questions later too.